Hello, and welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, and I'm coming to you as part of the Digital Anatomic Pathology Academy, a joint venture with the Digital Pathology Association and Path Presenter. Our cases come from the files of Path Presenter, as well as from the University of Oklahoma Health Sciences Center, where I serve on the faculty. Our case is a GYN case today. The patient is a 55-year-old woman who has been noting some rather severe and increasing abdominal pain. On exam, she's found to have a uterine mass, but also a partially strangulated inguinal hernia. Given the presumption that her uterine mass is probably a fibroid, because she doesn't have other symptoms of neoplasia, and that the inguinal hernia is likely the cause of her pain, the gynecologic surgeons, together with the general surgeons, opt to pursue robotic surgery. So there are a couple of things to understand about robotic surgery. Of course, it was initially touted most especially for benign conditions, but now is also used in a number of neoplastic settings. And there are several advantages to the patient as well as to the institution. Shorter hospital stays, lower pain thresholds, or lower pain levels, and therefore less narcotic use, and also decreased blood loss. However, there is the payback of longer operative times and therefore higher procedural costs. So these other savings have to be significant to countermand those. As far as pathologists are concerned, the main issue is that of specimen integrity. And because of the rather small orifices used and the desire to not inflict greater discomfort by expanding or enlarging those, it usually means that the specimens come out in a fragmented, sometimes even morcellated fashion, making orientation sometimes a little bit difficult. And that was the case in this particular patient's situation. So we did manage to get some reasonable sized sections. And the first hint that something was going askew was this section from what appeared to be somewhere near the cervix. And as we see, we have a somewhat deep neoplasm here that's very blue with also areas of necrosis. As we look at this, we can see that these are high-grade cells. They're very closely spaced. In addition to having the necrosis, we can see that there's a very high intensity of the nuclear staining, indicating high DNA content. Under the magnification that we have here, you can't really make out much in the way of mitotic activity, but there is a lot of apoptosis, and there's not much in the way of architectural orientation. So mitotic figures were actually fairly readily identified. So initially, based on the exam, it appeared that there was just tumor here in the cervix, and so the rest of the specimen being morcellated, we took more sections. And in fact found a much larger and more dominant mass elsewhere in the uterus, which had a little bit more recognizable pattern. Here we can see this sort of organoid nesting and sort of rosette pattern in some of these areas, with, again, neuroendocrine type features and the pattern of neuroendocrine carcinoma. With the glandular features and so forth, we were concerned about other possibilities, and so differential staining was done. The tumor turned out to be very strongly positive with synaptophysin. I'll show you some of the stains later, and it was negative for any evidence of mucin. So diagnosis of small cell carcinoma was made. Typically, these are most common in the cervix, but endometrial versions do occur. And these tend to be slightly older patients with higher levels of parity. In terms of histology and so forth, it's very similar to neuroendocrine carcinomas that we see elsewhere. And in terms of behavior, they also tend to behave more aggressively than garden variety endometrial carcinomas. There have been some reasonable responses to treatments with adjuvant-based chemotherapy and sometimes radiation therapy. Particularly if the patients are lower stage, there may be some optimism there. And not uncommonly, these lesions can be seen in combination with other carcinomas, as in the cervix. We see it with adenocarcinomas or squamous carcinomas. In the endometrium, sometimes we can observe it with other types of endometrial adenocarcinoma. So here's a nice follow-up stain. This is chromogranin, and you see it's nicely, strongly positive. And this stains both the membranous surface granularity, as well as having some cytoplasmic granularity as a sort of backdrop, but most heavily concentrated along the membranous surface. Staining with CD56 also was positive, but can be somewhat more spotty in this tumor. So these are uncommon tumors, but our final sign out is small cell neuroendocrine carcinoma of the endometrium with involvement of the cervical canal, making it a stage 2 tumor. And as I noted, these often present at stage 2, stage 3 at the time of initial diagnosis. Our patient on further evaluation was found to have lung metastases and therefore would have been stage 4. Lymphovascular invasion readily identified. So thank you for joining us for this case today. It's somewhat of an unusual case, not frequently encountered, but being aware that it can occur will help you to avoid the pitfall of misdiagnosis. As always, we welcome your feedback and comments. Please subscribe so you'll catch our future releases on the channel, and we hope to see you again soon. Thanks for joining us.